moving towards the very last session before the lunch break. Gestational diabetes is the most common medical pregnancy complication worldwide. Without proper management, it can lead to high blood pressure, increased risk in LUCS and mental health condition, and also complication for the baby. So to talk on time for paradigm shift, should we treat early GDM? We have our eminent speaker with us, Professor Dr. Samar Banerjee, the father figure of endocrinology, Vivekananda Institute of Medical Science, Kolkata, editor-in-chief, Journal of Clinical Diabetology. And to chair this session, I would like to invite Dr. Sanjay Kesha, HOD, Department of Diabetes and Endocrinology, Narayana Super Specialty Hospital. He is one of the founder member and torch bearer of Howrah Diabetic Society. And we have another chairperson with us, Dr. Shukumar Barik, Senior Consultant Gynecologist, Narayana Hospital, Howrah, Professor IIM SAR, Holdia. He is one of the examiner of MBBS, MD and MRCOG Part 3. I would like to request both the chairperson to please be seated and introduce our eminent speaker.
Right. After that wonderful session, we are now requesting Professor Samar Banerjee, who needs no introduction. You can see his achievements, phenomenal achievements from Samar Banerjee. And he has some seminal work in the field of diabetes and academics as well. And he's now going to talk about time for a paradigm shift. Should we treat early gestational diabetes? So welcome to Professor Samar Banerjee.
Thank you, Dr. Sanjay. I'm very lucky they have selected me for all the programs of the Howrah Diabetic Society. And every time I tell, as per my knowledge goes, the knowledge is gradually receding, there is cerebral atrophy because of age. That in India, I move from place to place, but I have never seen a district has developed a diabetic society. This is unique for Howrah. But there are two types of diabetologists in Howrah. One are RI, resident Howrah, RH. Others are non-resident like Sanjay sir. I am going to discuss a very important point, very upcoming point, very developing point. That is the early gestational diabetes. I am not going to confuse your brain with this, that what actually happens in pregnancy. Briefly, there is heightened insulin resistance, beta cell depression, oxidative stress, inflammation, etc., all lead to gestational diabetes. I personally feel very enlightened by becoming successful in pregnancy diabetes treatment. This is very difficult part because you cannot take a drop of blood from the fetus, you cannot give a medicine directly to the fetus. You are targeting for an best fetus without any problem, but you are treating through the mother. So it is an indirect treatment rather. I think this is very difficult, but if you practice it will be made very easy. When we are students in 1960s, diabetics were not allowed to conceive. I have seen, they are told by gynecologists, I am sorry Dr. Barik, well it is also your experience. You are diabetic, you should not conceive. 2024, I challenge you, any diabetic, it comes preferably before pregnancy and follows all the recent advices, we can offer her a very healthy and laughing child. And this success and this pleasure is more when we get a lady, elderly lady with 4 or 5 abortions and then comes with a very beautiful child. And I don't get any more pleasure than this. This is my personal experience and this is a great challenge, but this is possible also. Early detection and initiation of treatment in GDM is important because with undetected GDM, particularly if you diagnose late, there are problems of in pregnancy-induced hypertension, preeclampsia, urinary tract infection, cesarean delivery, fetal macrosomia, birth trauma, neonatal hypo, and future development of diabetes, hypertension, etc. This one paper, Bengali people, Saptasi Bhattacharya, during screening in pregnancy, A significant proportion of women do not reach the threshold for overt diabetes mellitus, but fulfill the criteria used for diagnosing conventional gestational diabetes. The target fasting should be round about 90, postprandial below 120. My target is much lower. Why? I will show what is normal blood sugar value. I apologize, till day more than 50% of patients are not either diagnosed or reaching the ideal level. Today just I saw a patient for pregnancy for more than 6 months, postprandial 252, fasting 90, treated with basal insulin. What will happen to the postprandial blood sugar? Early detected GDM refers to intermediate degree of hyperglycemia detected before 24 weeks of pregnancy that fulfill the criteria for eGDM but fall short of the threshold of the overt diabetes, and fasting more than 92 is considered as eGDM. In eGDM, postprandial blood sugar may be normal also. What is the guideline of ADA? We don't follow ADA guideline. We are the follower of the DIPSI guideline, for which I was an active worker and also I was the founder member. Because our country is a highly insulin resistant country. Pregnancy, diabetes occurs more. ADA tells you do the blood sugar after 24 weeks. In that case, I will show Indian paper, more than 61% patients have already developed diabetes. But ADA shows test individuals with risk factors and consider testing all individuals for undiagnosed diabetes. How to assess the risk? When a patient goes for draining an abscess, they go for 1 blood sugar. Pregnancy planning, before pregnancy planning, no blood sugar done. They usually reach to the gynecologist after 2 or 3 months with very high blood sugar level. Treatment may provide some benefit. Rest you assess for 24 to 28 weeks. Our recommendation, you do blood sugar and thyroid testing the moment the pregnant patient is coming to you. For all polycystic women, I tell before marriage, before taking pregnancy, you must have a blood sugar level done. ADA guideline, before 15 weeks of gestation, test individuals with risk factors, and also you go for 24 to 28 weeks for the others. This is an Indian paper published by Professor V. Sesaya, who is my guru. Out of 87 diagnosed GDM, in the first trimester, 62.1% were labeled as diabetic. And if I don't do blood sugar in the first trimester, we will miss these cases. So DIPSI recommends screening at first visit. This is another this is an probably Iranian study. 28.6% were diagnosed before 24 weeks. GDM before 24 weeks were older and more likely to be obese, and they have identified risk factors for GDM, particularly polycystic ovary or features of insulin resistance like acanthosis nigricans, dyslipidemia, etc. Previous gestational diabetes 20% cases, first degree diabetes relative, mother, father, etc. 80% cases, prior delivery of fetal macrosomia and previous history of congenital fetal abnormality. These patients are supposed to develop diabetes much earlier. What is the normal pattern of glycemia in pregnancy? You see, fasting round about 71 point plus minus 8, 1 hour 109 plus minus 13, 2 hour 99 plus minus 10, and suggested postprandial target at 2 hours less than 110. How many of you are maintaining less than 110 2-hour value in pregnancy? So this should be kept in mind, and any value above normal, that is fasting above 70, postprandial 1 hour above 110, and 1 hour above 109 and postprandial above 110 are all abnormal and damaging the fetus. This is an information that fetal abdominal overgrowth, which indicates fetal obesity and also insulin resistance. Normalization of fetal hyperinsulinemia, which is related with maternal hyperglycemia, is the most important factor for prevention of fetal abdominal overgrowth. Much earlier diagnosis can prevent this and can prevent macrosomia, cardiovascular disease, and many problems. One study, a retrospective study by Bartha et al. showed that these early screening can avoid diabetes-related complications such as polyhydramnios, fetal anomaly, and preterm birth. They can also prevent emergency cesarean section, neonatal hypoglycemia, and macrosomia. French study, more likely to be insulin treated during pregnancy. Early diabetic pregnancy, more likely to require insulin, gained less gestational weight gain, had a lower rate of preeclampsia, and similar rates of large for gestational age and shoulder dystocia. Australian diabetes in pregnancy study recommend screening high-risk women before pregnancy. Early GDM detected had a significant lower newborn composite outcome frequency like hypoglycemia, birth trauma, NICU admission, stillbirth, neonatal death, respiratory distress, etc. Caesarean section, hypertension disorders, postpartum hemorrhage, birth weight more than 90% percentile, macrosomia, and preterm birth frequency were not significantly recurrent in this study. And therefore, we require diagnosis much earlier. A retrospective study, early gestational diabetes account for majority 65.9% of all GDM. This is a study from Thailand. And who are they? Age 30 years or below, previous GDM, and strong family history of diabetes. And they have increased risk of preeclampsia, large for gestational age, and NICU admission. Hypertensive disorders in pregnancy, including preeclampsia, preterm delivery, caesarean section, and neonatal jaundice, are all high, and also macrosomia. At conception, EGDM women were older and had higher body mass index. Mean fasting, 1 hour, 2 hour postprandial blood sugars are all higher in this case. Pregnancy outcome of early detected gestational diabetes at conception, women who were older had higher body mass index, mean fasting and postprandial blood sugar was much higher. Early onset diabetes versus late onset, past history of GDM, macrosomia, and stillbirth. Those ladies with this history will have more GDM, and they will have more recurrent UTI, polyhydramnios, reduced fetal movement, intermittent fetal demise, macrosomia, fetal birth trauma, lower Apgar score, and neonatal ICU admission. Rate of preterm birth, hypertensive disorders, labor pain problem, caesarean section are all high. But most of these adverse pregnancy outcome can be prevented through early registration and screening, close follow-up, growth ultrasound, and evaluation of the diabetes and other stage before pregnancy. Observational study shows GDM was diagnosed either at the first antenatal visit when fasting plasma glycemia were more than 5.1, that means 92, or after OGTT. The early diagnosis group had 65.7% women. More primary gravida women were in the late diagnosis group, multi-gravida more early GDM, and early diagnosis had more obese women. In the early diagnosis group, GDM was more frequently diagnosed in women who gained, while in the late diagnosis group, weight gain is less. Fasting plasma glucose was higher in the early diagnosis group. Polyhydramnios and preeclampsia, macrosomia, large for gestational age are all higher. Another study, prevalence of GDM in first trimester was 15.5. First trimester fasting plasma glucose was significantly correlated with both neonatal birth weight and birth weight centine. First trimester fasting hyperglycemia adverse pregnancy outcome. I am just directly coming to the conclusion. Higher first trimester fasting glucose within what is currently considered a non-diabetic range increase the risk of adverse pregnancy outcome. So fasting more than 92 in pregnancy is phytotoxic. Early detection and treatment can prevent all these complications. This is another study of 58 studies on early gestational diabetes. Incidence was 0.7 to 36.8%. Previous history of GDM, family history of diabetes, and multiparity were more in the eGDM group. The incidence of postpartum dysglycemia and the need for insulin was higher in women with eGDM. Why does eGDM occur? It is due to a greater decrease in insulin sensitivity and also greater insulin resistance in women with effective gestational diabetes with quantitative insulin sensitivity check index decrease. Another study showed that women with normal glucose level in early pregnancy, but women with early pregnancy hyperglycemia had higher BMI. So, higher BMI, higher insulin resistance and insulin secretory defects or dual defects of beta cell dysfunction and insulin resistance happens to be the cause of this. What happens if we do not treat? There are problems I have discussed. The need for insulin and or metformin is also greater in the eGDM group. Treatment of gestational diabetes diagnosed early in pregnancy. David Simmons did one randomized controlled trial known as toboggan study and performed a randomized controlled trial and did blood sugar before 20 weeks and compared with patients pregnant after 24 weeks. The results support the observation that hyperglycemia often occurs before the 24 to 20 weeks. Immediate treatment of gestational diabetes before 20 weeks gestation led to a modestly lower incidence of a composite severe adverse both neonatal and maternal. However, between group difference with respect to pregnancy related hypertension and neonatal lean body mass were not significant. There is also a possible benefit of early treatment with respect to the common adverse neonatal outcome. I have all discussed, I am not going to details. Perinatal outcome in early, late and gestational diabetes toboggan study, they have also mentioned the perinatal complication for the neonatal respiratory distress, phototherapy, requirement of neonatal intensive care units, etc., low for gestational weight. These are all less if you diagnose and treat from the early gestational diabetes. Why there is need for testing glucose tolerance in the early weeks? In a cohort of 11,785, very big point, there was available of 9,282 pregnant women, and in them diagnosis of GDM was made in 8% cases. Among them 31.5%, 43.2% and 23.3% were in the first, second and third trimester. So, first trimester 31.5%, and as usual fetal loss, past history of fetal loss, history of pregnancy in the family, etc., are the determining factor. Among women undergoing early screening, the diagnostic yield for diabetes is highest among women with class 3 obesity. So, obesity is a determinant of early gestational diabetes, and this is a curve which shows with gradual increase of the body weight, the incidence of effective gestational diabetes is coming more and more. Casson et al., they studied neonatal outcome were not different. Other studies demonstrated that women with early pregnancy hyperglycemia were at increased risk of adverse maternal and fetal outcome. So, there may be difference of presentation in different studies. The importance of screening early to detect overt diabetes mellitus was proposed by IAD PhD, who also supported, FIGO also supported, Australian Diabetes Society also supported. Only American Diabetic Association and ACOG are claiming you do it after 24 weeks, only for selected cases where you know there is risk, you do it early. These I all discussed about the early diagnosis, but we are claiming whether we can predict pregnancy diabetes before the mother is pregnant or the very early in the pregnancy period when blood sugar your so-called is normal. So, prediction is more important. When we even diagnose at the early stage, there are some complications which could not avoid. So, this is necessary, and when we predict, first time the study, NIH study suggested A1C of more than 5.3 at 10th week. A1C more than 5.3 at 10th week, you can predict that patient will develop pregnancy diabetes. And so far no explanation has been given for prediction as well as prevention of gestational diabetes. Postprandial blood sugar at 10th week, more than 110, predicts gestational diabetes. Hence, blood sugar should be brought below 110 in pregnancy so that GDM does not develop to prevent the fetal cells and fetal insulin secretion, changes in maternal metabolism, etc. This is a very important study and just published 2024, you look, and they have shown, you can claim that if we do blood sugar for so many patients, so early a pregnancy, whether it is cost benefit or not, yes, the intervention was more effective and they tended to be less costly and also rewarding. They analyzed fasting 1 hour and 2 hour values. Conclusion, everything early always better. I believe early to born, early to bed, early to rise, early to marry and early to expire, for which I am waiting, is always better. And similarly, early gestational diabetes detection is better. A considerable number of women are diagnosed as having intermediate levels of hyperglycemia in early pregnancy. Still, there is no consensus internationally. Fasting and OGTT and A1C have been explored. A1C should be less than 5.3, fasting less than 92, postprandial to or below 110. Association between early pregnancy, fasting, hyperglycemia and adverse perinatal endpoint. Higher pre-pregnancy BMI could be additional determinant of unfavorable outcome. Patients with bad obstetric history, obesity, hypertension, polycystic ovary and strong family history should be particularly taken care of. Treatment of early GDM demonstrate conflicting results partially attributed to heterogeneity in study design. Well-designed multi-ethnic, multi-centric clinical trial to define diagnostic and therapeutic strategy for eGDM, taking into consideration the clinical economic implications are needed. We have got one study which have shown it is cost benefit. We have shown a very big study, toboggan study. Toboggan study has shown that early GDM is both dangerous for the fetus and the mother, but I regret, I apologize, pregnancy diabetes care in our part of the country is very poor. More than 50% or something like that blood sugar is not done. If not done, they are done very delayed, and even done, taken not properly care of. Majority of the practitioners are practicing their own criteria. They do not practice the DIPSI criteria which is labeled by the government of India. The target treatment, fasting should be brought down near about 90, postprandial below 120, and A1C, 2 hour postprandial below 120, and A1C should be brought below 6, preferably round about 5.5, etc. not. I am grateful to them who taught me gestational diabetes, Saswati. This child is now more than 12 years, and this one, Shormishta, and also another, that is Nomita. I am grateful to them because pregnancy diabetes you can learn only applying your knowledge and getting the result. And I am also grateful to you for my successful 10 books, and this is the last book, Gastro-Diabetes, all are available in Amazon. Pregnancy book was an early one. Thank you for your patient hearing.
Thank you very much, Professor Banerjee, for your wonderful presentation and very thought-provoking one. And I'm sure the learned audience has gone through the Lancet series on GDM published in July this year. And effectively, what you have warned, everything early is good, is one part of the story. And you have already warned that a significant number of people never had any blood sugar done in the early pregnancy at all. So we are facing a different type of problem. One is not had a blood sugar in the early pregnancy. Second, there are people who is coming to the clinic in the later pregnancy and having a overt diabetes. We have seen in 25 years, Sanjay and me, Dr. Professor Shah and myself has in our Narayana multi-speciality hospital. And we are still struggling. There are many people are not following the IID PSG criteria. So there are few problem remains. If you are talking about early and how early, that's a big question because traditionally we do the GTT between 24 to 28 weeks for obvious reason because of the placental function and we detection is early. So logistically, if you are thinking about doing it early in all, so doing it early in the risk factor group which is recommended is one. Doing it in all in early means you are talking about at the time of anomaly scan, that means around 20 weeks. So you are putting it forward from 24 to 28 weeks to 20 to 24 weeks. Will you be repeating another one after 24 weeks, 25 weeks? That's my number one question. And second thing, it is yet to be proven that if you detect early, how many you have missed? Because they have no study who has done 2. So if you do early, suppose you have done a GTT in IID PSG criteria at 20 weeks, and in our hospital and globally, it has been shown about 12 to 14% you will have the incidence of GDM, then there is a possibility of missing because you have not done it little bit later. So please, your opinion please. So will you be doing it twice or you will be happy to do it at 20 weeks and forget about it?
IODPC criteria do not work in our place because the genetics is not American, the patient is not American, the child which will be born is not American. Number one, I am telling why. Our country is more insulin resistance and they have got more beta cell defect. I have shown the paper Indian by Professor V. Sesaya that 6 to 1.3% pregnancy hyperglycemia diagnosed in the first trimester. If you wait for the 24-week study, if you wait for up to the 24 weeks, you miss so many 61.5%. You have no right to neglect them or deprive from the earlier treatment. Second, which blood sugar should be done? For corporate hospital, 4, 6, 8, 10, 12, A1C, CGM, okay. But you will have to think, 80% of the pregnancy occurring in the rural area. I have got a younger follower, Bhavotarini from South India. She has shown by paper that from rural area in the morning after doing the household job, after providing the feeds to the cattle, after sending the husband to the work and the school for the child, the lady is coming to the hospital from a distance of 60, 70 kilometers. If I tell her, you come tomorrow morning with a glucose packet, I will take fasting 1 hour, 2 hour, 3 hour value. Next day she will not come, not possible. Second, Government of India with the recommendation of DIPSI, I am very proud, DIPSI is the only diabetic subgroup whose recommendation is accepted by the Government of India, no other subgroup. They have allowed a very good quality of blood sugar machine. From this stage, I will not tell the name of the company, but it should be ISO standardized, not cheaper one, ISO standardized blood sugar. If I take a blood from the lady and tell, you wait for 4 hours, at evening I will tell you the report for the normal. The lady will have to leave the hospital, the lady will go to rural area. You will have to think in the best level. So, government has asked to do the blood sugar if required in good quality glucometer. See whether more than 120, 140 or not. 140 to 190 start with lifestyle modification. More than 199 start with medicines. Medicines, insulin for all purposes. Best insulin is fast acting aspart for pregnancy. Metformin, not at all fetotoxic. Very, very wrong marketing against this. First trimester, Government of India no data was published, so Government of India recommends that metformin should be given from the second, third trimester. WHO, FIGO, Australian College of Gynecologists, they have all recommended metformin you can give from the very beginning. Keep it in mind, it ties side effects like nausea, vomiting. Polycystic ovary, those who are controlled on metformin and induce the ovulation and pregnancy. If you stop metformin in the first trimester, chance of abortion is 36%. After first trimester in polycystic, if you think I will not give, okay, I don't mind, but keep it in mind. I repeatedly told that etiology of pregnancy diabetes or GDM is insulin resistance, that it only ameliorated by metformin, aggravated by insulin. We will have to practice. I went to Bangladesh several times for the conferences. They have made a system when during marriage the kolma is read by the clerics, Maulavi. They say, and it is also written, do one blood sugar BP you become pregnant. I again repeat, when a patient go for chani operation, for draining an abscess, for all surgical methods or all intervention, they do blood sugar, but they do not do before pregnancy at all. It is a regular finding. But what is the best scope for polycystic ovary patient? You tell you have high chances of having pregnancy diabetes, so control your polycystic ovary insulin resistance status, and then before conception do the blood sugar. To them who are obese, who have got very strong family history, who have got hypertension, dyslipidemia, past history of macrosomia and fetal loss. Thank you.
Good afternoon, sir.
Professor Mojumdar, please.
So the question is not this. Question is that if you diagnose the early GDM, vis-a-vis you are diagnosing the standard GDM after 24 to 28, will there be any benefit? Or
I am very sorry, I have shown multiple papers.
Let me finish, sir. Let me finish. So this is one. Second is that the usually standard approach is that whenever the patient comes, we usually check the blood sugar. So first trimester usually all gynecologists check. Mostly, say that is a criteria. So if it is detected in the first trimester, that is already over. Our standard approach, what is standard approach? First trimester we check, then we check 24 to 28 weeks. The question is that you have raised is an early GDM that we appreciate, we agree that possibly it is required to be done, but the question is that if we detect and if we treat, will there be any difference? That is the question. Not how to treat the GDM. Look into only the early GDM.
Should I go through my 40 slides where I have shown about 20
give me
research
one line
articles,
answer. Sir, one line answer.
including the Topocom study by David Simmons et al., which was done on the very big. They have shown many advantages, but not all. Some have shown that neonatal outcome is not that different, but many outcomes they have shown. If they allow, I can show all my slides which have shown what are the benefits. Again, I accept there is no consensus now. Second, pregnancy is a disorder of high insulin resistance, hypoglycemia. Theoretically, what we problem create by diagnosing and treating from the early stage, every case we are not going to start with medicine. At least lifestyle modification can be done. This is and of course, if first trimester blood sugar is normal, you will have to do in the second and even in the third. Sorry.
I entirely agree with you that Topocom study is only recommended in risk factor groups, not recommended to all. And I entirely agree with you, at the current moment, there is no evidence which shows there is a definite improvement in the outcome if you detect it early. So, an unanswered question is whether you are, the answer which has not got, that if you do it early, are you going to repeat it later on? So that is not answered yet.
Those who are interested, please send me email, drsamarbanerjee@gmail.com. I'll send you 40 articles in my favor.
Actually,
40 articles I can send you.
One rationale for
Sir.
early early testing for blood sugar is that the period of organogenesis, if you remember the fetal organogenesis, the period of organogenesis, it begins much earlier, within 3 to 4 weeks. If brain starts developing, other organs also within 10
Yes,
to
sir.
10
By
to
9 to 10 weeks, everything finished. And whatever you do after that,
That
organ
is
defect is
useless.
there.
Yes, it stands to reason that we should do it as early as possible.
3 to 9
before
weeks is the embryonic period. We are not discussing about having a blood sugar testing, either is a fasting or PP or both or A1C in the early trimester. The question is not that. That is, everybody is doing it. The question is whether you want to go for early GTT. That is the question. We are not addressing that point. That is taken care of.
Period of organogenesis, if you intervene after the period of it is no use. So it stands to reason that we should do it as early as possible.
No. The reason why the GTT is done later on is because of the placenta is in peak, and that is the conventional reason why the GTT is so long is done between 24 to 20 weeks. Now this question of early GTT detection early is in question, and that is not answered yet, what Professor Majumdar was pointing.
But what I would like to perhaps take the side of Professor Samar Banerjee, largely because you have to understand what the background rate of diabetes is in our population. You see, the Western world, Caucasian, where the background is not very high, they talk about risk factors. You being an Indian yourself, you have a risk of which is double or triple that of, এটাই তো উঠে গেল ওর জন্য the DIPSI guidelines টা আছে
DIPSI.
Many studies are there. I am ready to send. Then I will draw back all my lectures. Many
Sir,
slides.
DIPSI
And
guideline.
with these obstinate ideas, we are damaging the fetus. We are damaging our future society. We are offering our society with an handicapped child who are coming with heart disease, hypertension, diabetes.
Sir,
at the age of 12.
one more question and then.
But that is beneficial for the practitioners. More and more diabetes is beneficial for the practitioners. That I agree. You may resist that. Thank you.
Last
Sir, one
question
point, sir,
and
one
then we
point.
time out please. Yeah.
One point, sir. Sir, very elaborate discussion. Thank you, sir. But one question remained unresolved. That is there any lead time benefit for this type of activity? Early GTT, lead time benefit. Lead time benefit. Lead, L-E-A-D, lead.
That is, this card fetal total development, organ development occurs before 11 weeks. Whatever you want to do, you do it before. After the organ is damaged, you have stimulated the fetal beta cell for hyperplasia, secreting more and more insulin in the fetus and damaging the fetus, and which in turn will damage the mother in future. More chances of diabetes, hypertension, heart disease in future is losing for the patients, profitable for the doctors. Thank you.
Thank you so much, sir.
Thank you very much. Give a big hand, please.
It's time to felicitate our speaker and honorable chairperson. I would like to request Dr. Sanjay Shah on behalf of Howrah Diabetic Society to please felicitate them. Thank you so much.